Hello, guys. It's Mrs. Lloyd here, Wednesday, March 25th. I'm going to run out of animals soon for my videos, but here's a new one. This one's Jeffrey. He's super sleepy because it's the morning and he's not used to us being home and interrupting their daily naps. Also, excuse my appearance here. I went to my gym virtually this morning and did a little workout in. I hope you guys are staying active even though you're at home. It's really important for you. So today we are talking about lung volumes and respiratory diseases. And you have a homework assignment to do after we go over these brief, hopefully, notes for you. There was one thing I forgot to mention yesterday in the notes, so I want you to add this real quick. On page 5, we labeled this crazy picture here. Down at the bottom, you don't have to write this formula down again, but we talked a lot yesterday about what carbon dioxide does when it gets into your bloodstream. And the main thing that's important that you know is it doesn't stay as an acid. It gets churned into a bicarbonate ion. Now, what I didn't mention to you guys yesterday is this doesn't just happen automatically, naturally. What I failed to mention to you is it requires this very important enzyme called carbonic anhydrase, NH. And you're going to write that just underneath your picture here. You don't have to write the formula again. You have it hopefully twice in that picture. But it at least is going to show you that it doesn't happen automatically, but there's a very, very important enzyme that we have that does that conversion for us so our body doesn't stay acidic. Okay, so before we jump into lung volumes, I want to briefly talk about how our body is controlling our nervous system to control your respiratory rate. I did quite a bit of abs, six-pack abs, and cardio this morning, and my breathing rate significantly increased. That reminds me, I never stopped my workout. Man, that thinks I've been working out for 3 hours and 10 minutes. That's not accurate. But we have, when we work out, your breathing rate is going to increase. Let's talk about what controls it. Obviously your brain, but there's, as we know from our nervous system, there are sensors throughout our body, and then those sensors send that information to your brain, and then your brain sends out a signal on how to respond. So the sensors in your body that control your breathing rate are actually located in two places. One is in your heart, and the other one is actually in the brain itself, the cerebral spinal fluid around your brain. So remember, in our sinuses and the spaces in our brain, and also just surrounding the very outside of our brain, most of the things that are shown in blue on that brain picture right there have cerebral spinal fluid. Well, your cerebral spinal fluid has carbon dioxide levels in there. When you have an increase in carbon dioxide levels, because I'm working out my muscles, right? And so I'm doing more ATP and I'm producing more carbon dioxide as a byproduct of all that muscle activity. My CO2 is going to increase, and it increases in my cerebral spinal fluid, which then is one of the signals that says, hey, I need to exhale more quickly to get rid of all this acid. The second sensor is located in your heart, right in the aortic arch. That little line there is right on the aortic arch, and it is showing you that when oxygen levels decrease, because again, working out, getting using a lot of oxygen to supply my increased muscle activity, I'm going to have a decrease in oxygen, and then my heart is going to sense that. So you have a sensor in your brain and you have a sensor in your heart. The one in your brain shows a spike in carbon dioxide. The one in your heart shows a decline of oxygen. Okay, and so carbon dioxide, when it goes up, I need to increase breathing. When oxygen goes down, I need to increase breathing. They work the same. Okay, so the nerves traveling from those areas, the one in my brain does not have to travel very far to go to the brain. It actually pretty much stimulates it directly. And the one in my heart, there are afferent, remember that's going towards the brain, afferent nerves that are going to send that signal that says, hey, we need to breathe faster to get more oxygen and get rid of all this excess carbon dioxide. So it sends the signal to my brain. Specifically, the part of my brain that controls this is my brain stem. So kind of deep in the back part of the brain, specifically your pons and the medulla oblongata. Both of those are your breathing control centers of the brain. They receive that information. CO2 is high, oxygen is low. We need to increase our respiratory rate. Well, how do we breathe? It's just the muscles of my thoracic cage. And so that's what's going to be stimulated. So the nerve signal going out to my body, remember, is going to effectors of my body. And the two main things are going to be the nerves going to my intercostals. So my intercostal muscles, they are all surrounding my rib cage, as well as a very important nerve. I think we jotted down before, the phrenic nerve. It is the nerve that stimulates your diaphragm. Very important nerve. If it gets disrupted, the person can't breathe anymore. It's an important nerve for your body. Those are the two main pathways, the efferent pathway going out to my effectors. Effectors are always muscles, sometimes glands, to stimulate or increase breathing. So as I was getting my sweat on this morning, I was breathing more deeply because, thank you, nervous system, telling those muscles to work harder. I didn't have to consciously think about it as I was working out. All right, so that's how we control our breathing rate if we're using up too much carbon dioxide or, if we're producing too much carbon dioxide or using up too much oxygen. All right, so this picture, I believe, is right on top. I dropped my paper on page 5. And if you want to shade it in and color it, awesome, you sure can. The colors are sort of nice here. I'm going to use the picture from your textbook, so the colors are a little bit different, but the diagram is exactly the same. If you're using a black and white version, you can't tell the difference. So I know that this piece of the picture isn't there, so you can just draw these brackets on the outside, or if you want to, you can even extend those lines out a little bit more. This is a picture from your textbook. Don't have it handy what page number it's on, but it's around the 800s. All right, so this is a picture showing us the different lung volumes. And when we are talking about lung volumes, this is a good way that doctors can diagnose certain issues, depending, because there's a good medium range that people are supposed to be in for their body. Men and women are a little bit different because women tend to have a smaller rib cage. We tend to have a smaller lung capacity. And so females' numbers are a little bit lower versus males. So this is going to help diagnose asthma or tuberculosis or other diseases that we're going to talk about in a minute. Had we been in school, I had a lab for us to test our lung volumes. But if you are super excited and super bored and you want to do a little science at home, I have a optional lab that you can do to test your lung volumes, all from home. All right, so these different lines and sections are indicating these different types of volumes. So volume is basically how much space is in there. Now, the inspiratory reserve volume, notice there's a big spike there. This is a reserve volume of extra space inside my lungs. Right now, I'm breathing normally, maybe a little excited because I get excited when I teach. But my regular breathing is occurring. That light blue line in the middle, this small section here is sort of my regular breathing. This big spike, inspiratory, meaning would I take as big of a deep of a breath as I possibly can? That's the extra reserve volume that I have to inspire and inflate my lungs. So take the biggest, deepest breath you can or you have all day. That is your extra inspiratory reserve volume. All right. As I mentioned, we have this regular when you're just being relaxed and breathing in and out normally, right? That is called the tidal volume. And these numbers are just kind of average for people, what doctors would compare your number to see if you were sick or ill or something. So the tidal volume is just breathing normally, breathing regularly, okay, in and out. Now, if I said exhale as much of the air as you possibly can, push every little bit of air out as much as you can, okay, that's going to be this dip that goes down right here. That is your expiratory reserve volume. What's important to know is as you are breathing normally and regularly, you have extra on top where you can inhale more deeply, and then you have air left over in your lungs down below that you can exhale, but we don't as we are normally breathing in and out, okay? Now, we also have air in our lungs that never, ever, ever leaves. Even as much as I force the air out, as I expire all of my reserve volume as much as possible, there's still air left over, and that's this bottom part. It's called the residual volume. This is super important. Not all the air leaves your lungs when you do exhale because we don't want those alveoli to collapse. We want to keep everything inflated, and so your body does not let you exhale every single thing, okay? So even when I go from the deepest breath possible to exhaling everything out of my body as possible, I am only going from the tippity top of my inspiratory reserve volume to the bottom of my expiratory reserve volume. I don't ever touch that residual volume. That stays in there forever. Well, I mean, it gets recycled, but it never totally empties every inch of air out of your body. So we still have air left over, the residual volume, the leftovers. Now, when we talk about your total lung capacity, that's what this bracket is your total lung capacity. But one more important one is we want to know from that deepest breath to when you exhale the most, what that is. And we call that your vital capacity. So it's basically what capacity of volume is available from a biggest inhale to an exhale. Okay? How much is our vital capacity? So vital capacity is made up of your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. For the test, it's not important. You guys remember these numbers. It's nice if you wrote them down. You don't have to. If that's one less thing you don't need to remember. But do know your vital capacity is made up of these three things. The total lung capacity, though, includes the residual volume, how much air fits inside your lungs completely and totally. A doctor can't get a real good measure on this number, but we can get the vital capacity number. And so if you've ever had asthma or had a respiratory therapist, they test this for you. All right. I'm going to switch screens over. This isn't on YouTube that I could find. You probably found actually a similar video, but it's through some of the teacher resources I have. But this is showing you, this is what we would have done in class had we been able to do this lab to figure out what your guys' lung capacities are. However, there's an at-home lab that you can do if you'd want. So this is kind of the old school, we call it a spirometer, and it's a way of testing your lung capacity. So we'll watch this little video together here.
All right, before you turn on that, go ahead and breathe. So right now, our subject is breathing to the room, breathing normally. Now the subject is breathing into the spirometer, the classic water-filled spirometer.
One thing I want to point out to you is this is like the old school version, and there's water in that tube. And if you notice the silver thing moving up and down as she's exhaling and breathing in, she's changing volume because we're measuring volume, but water, and that water is pushing the needle up and down, and you'll see that in a minute. But there's water in there, and it's changing volume as she's breathing.
Breathing normal tidal volumes. We'll take one more tidal volume. And I want you to take a big breath in. Pause and blow it out as hard as you can. Blow, push, 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 push. Okay, come off. Okay, take a break. We got time. I'm going to give you an obstruction now.
Okay.
So there's the mouth piece that she breathes through. This is the obstruction. So air will be reduced to not this area, but this hole right here is what she'll be breathing through. So there's the obstruction.
So imagine you have asthma. One thing you could even like just do this at home is breathe normally and then take a straw, plug your nose and try to breathe through a straw. Sometimes that happens with some of these pulmonary diseases where your air is obstructed. Asthma closes up your respiratory passageways. And so this is a demonstration of somebody with an obstruction who's not healthy, what that might look like.
Most people do hate the obstruction. Go ahead and breathe. Breathing to the air. Now again, small volumes. Now breathing to the device with the obstruction in place. Normal tidal volumes with the obstruction. Now one more. Now inhale all the way. Give it everything you got. Pause, blow it out, push as hard as you can. Push it out, push, 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 push. And come off. What's noticeably different with the obstructed breathing is the FEV1, the forced expiratory volume in 1 second. You can see again if we're coming over approximately 32 millimeters, which would be that line in fact, in 1 second, that's how much of the total vital capacity was pushed out in 1 second and obstructed versus how much was pushed out in the unobstructed. This is the main value that changes with the obstructive lung disease.
So as you can see from that last little clip there is you can't exhale as much of your tidal volume as quickly. Right? It takes longer to exhale because of an obstruction, which is common with many different diseases. Speaking of which, we're going to go over. If you go through my PowerPoint, I'll also link this in Plan Book, but the next slide is an at-home experiment. If you want to basically make an at-home spirometer, you sure can. This might be great if you have younger siblings and you're in charge of keeping them entertained throughout the day. It's not required. Okay. The one thing that might be difficult to find in your house is a little, like a tube, like a hose that you can see here. But if you have something that will work, this might be a fun thing to do. So I'll just include the video link for how to do this at home experiment. Not required. Okay, last little bit are some respiratory terms and diseases. This is not written out in your packet. So if you've got some extra space, we're almost all done with our notes. Your test is going to be Friday, or you could jot this down on a separate sheet of paper for this. So some of these are just basic terms and some are diseases. These NEA endings are really common for the respiratory system, referring to breathing. So apnea, you've maybe heard of sleep apnea before, is when apnea happens when you are sleeping. This is oftentimes associated with snoring, but what apnea means is breathing cessation, meaning cessation, stopping. You're not breathing. So if you came across like a accident or something and you check to see if someone's breathing and they're not, they're experiencing apnea. Sleep apnea, when someone is snoring, and the sleep centers test for this, but you quit breathing in your sleep. And that snore that you hear is kind of a gasp for breath that you do experience. And so apnea just means stopping of breathing. Sleep apnea, it happens when you are asleep and it's associated with certain types of snoring, not all snoring, but some snoring. Asthma, some of you may suffer from this. This is basically inflammation of, I shouldn't say inflammation, it's the narrowing of your airways. If you remember, most of the respiratory tract, especially on the bronchioles, they were covered in smooth muscle. Now, when our body thinks it's fighting off some foreign molecule, maybe pet dander, maybe seasonal allergy, maybe an occupational smell, right? Like you might feel like a tightness or something because of a certain chemical in the air. Or some people experience this when they exercise. So those are the three types: exercise induced, occupational induced, usually chemical, something like that. Or I can't remember the other name, but it relates to things in the air. So like pet dander, seasonal allergies, pollen, things like that. But your body creates an inflammatory response to those things, and inflammation increases blood flow. And in the case of your airways, though, it constricts them and it squeezes them. And this is like breathing through a little straw. And so your airways spasm. It's that smooth muscle that squeezes. So inhalers have a chemical in there that's meant to release these vasodilators that are going to cause your airways and stuff to relax. Usually it's steroid based. That's going to tell you to open up your airways so you can breathe again. All right. Chronic bronchitis can be, it's usually slow to onset. Now, if you have a cold and there's a lot of mucus and you're having a hard time breathing, COVID-19 does induce bronchitis. That's inflammation of your airways. Right? So this would be deep down. This is when you go to the doctor and they are putting their stethoscope and asking you to breathe in and breathe out. They're looking and listening to see if there's any kind of blockage in your respiratory tract, especially mucus buildup. So when your bronchial tubes get inflamed because of an illness, itis, inflammation, swelling, they're swelling, and then mucus tends to build up and get stuck and trapped in there. Coughing sort of helps move that stuff up. Chronic bronchitis, though, is when this happens over a long period of time. And it can be actually deadly because your body's not getting enough oxygen. And we'll talk more about some other things related to that. Smoking is a major cause of this. Smoking actually is a major cause of many, many lung diseases. And people who are in respiratory therapy deal with lots of this stuff all the time. All right, dyspnea is if somebody is having labored or difficult breathing. So this isn't a disease, but like apnea is a term related to respiratory system. So is dyspnea. And this is labored breathing. Sometimes it basically means air hunger. You're hungry for air because you're having a hard time getting air into your lungs. The people who are being really seriously affected by COVID-19 and having to go to the hospital are experiencing labor breathing dyspnea. Emphysema, this is a disease where you basically have the breakdown or damage to your alveoli. This damage, though, doesn't cause them to collapse. Instead, they become larger because the walls, those very thin walls, are breaking down. This is caused oftentimes by smoking. It's a long onset that causes this, but it ends up having like shortness of breath. And so you feel like you can't get like a full breath of air when you breathe in, you can just take small gasps of air basically with emphysema, highly related to smoking as well. Eupnea is normal breathing, okay? Regular, healthy respiratory rate rhythm. Anytime someone goes in the doctor's usually going to listen to their lungs, listen to the breath sounds. So they're going to listen to see if there's dyspnea, eupnea, perhaps heaven forbid apnea. They'd probably notice if they weren't breathing though. And so those are something that get charted depending on how someone's doing. Hypoxia is when different parts of your tissue are not getting the oxygen it needs. If you've ever been like a kid or whatever and put a rubber band around your pinky or whatever, it starts to get like blue or purple, right? That's hypoxia. That's when you do not have oxygen getting to your tissues. If you're not getting enough oxygen in your entire body, you can experience hypoxia everywhere, Or if something's too tight and cutting off circulation, you can get hypoxia to just generalized area. If we're having issues with our lungs getting oxygen in, hypoxia is going to affect your whole body. Now, it tends to affect your outer extremities first, and you can usually tell this is happening by a bluish hue. That bluish hue is called cyanosis, like as in the word cyan is Latin for blue. And so that bluish pigment or hue someone gets if they're having a lack of oxygen is called cyanosis. The blue hue, hypoxia, is what causes it, lack of oxygen. All right, COPD. COPD is a chronic obstructive pulmonary disease, and smoking is the number one cause of COPD. And people who have COPD have an extremely high risk of death with this current virus, COVID-19. And guess what causes COPD is usually smoking. By definition, someone has COPD if they have both emphysema and chronic bronchitis. Both of those are caused by smoking. If you're experiencing both of those, mucus and buildup and obstruction of the lungs and the damage to the alveoli, you're defined as having COPD. And these things can kill you because you're not getting oxygen. Respiratory therapists deal with this stuff all the time and try to drain mucus and give breathing treatments and ventilators, so the machines that help them breathe. And right now, the hospitals, the reason why we're all home is because they're getting really run down. People getting COVID-19 who have a respiratory issue, they're not being able to breathe, and you can very easily die if that's not treated and you can't recover it. Unrelated, a different disease, not COVID-19, is tuberculosis. Some of you got a tuberculosis or a TB test done. It is a bacteria infection, but it's highly contagious. I mean, very highly contagious. It is spread through the air droplets, coughing, things like that. Someone had tuberculosis, I don't know about that for sure, but it is really commonly spread in prisons. Back in it's been around for a long time, but it's something that they take very seriously in prisons because of the kind of lack of airflow, close confines, and people sort of breathing the same air. It's really common there, but also people who are intravenous drug users. So doing drugs intravenously, like sharing needles and things like that. So tuberculosis, we talked about HIV last unit. Okay. HIV is when you have a virus that attacks your immune system. One of the most common things that kills people who have HIV, remember, they don't die from HIV, but they die from something else they can't fight off because it kills their T cells, is tuberculosis. And HIV is really commonly also spread through intravenous drug users because of the blood-to-blood contact. Many people who have HIV can or will contract tuberculosis around the same time because of sharing usually like pipes, things that they would smoke through and out of. You can spread TB that way because of the air droplets. And then also the added risk of having HIV by using intravenous drugs causes tuberculosis, and then that usually ends in death of the individual. So those two things get really closely united. Now, you could have tuberculosis and it has nothing to do with HIV. You can just contract it. It's very, very contagious. This is why they test hospital workers to see if they have any antibodies for tuberculosis, because you can sometimes be a carrier without symptoms. And so they want to make sure that you're not passing that along to people who are at risk for other diseases. But it's bacteria, but very infectious. And the reason it's also incredibly hard to treat. Most of the bacteria are drug resistant. And then ERDS, kind of fun to say, but it is sad. Stands for Infant Respiratory Distress Syndrome. I mentioned yesterday about surfactant, and surfactant is the lipid molecule that is secreted in the alveoli to keep them from collapsing. When a baby is born prematurely and they're not producing that surfactant, they can suffer from ERDS, Infant Respiratory Distress Syndrome. And this is really dangerous too. all of these diseases are very dangerous if people aren't getting the oxygen they need. Your body's not going to function like it can. So respiratory therapists, they are awesome. They do great work in keeping people alive and well. And not to mention all the other terrible things that can happen from smoking, chronic bronchitis, emphysema, COPD, as well as lung cancer. I'm sure you guys know that smoking is the leading cause of lung cancer, and lung cancer is nearly impossible to treat. I shouldn't say nearly impossible, but the death rate's really high for lung cancer. So this was your don't do drugs and don't smoke talk today, guys, because your lungs are super duper important. It helps you exercise. Huh, Jeffrey? He doesn't care. All right. Miss you guys. You have a test on Friday. Tomorrow will be review. And get ready for that. Till next time, have a great day.